So good morning, everyone. Um, I'd like to introduce myself to you for those who are not familiar with regards to who I am. I'm Shagun Fumure, and I am the program director of the multi-organ transplant student bridges training program. And I would like to thank the Transplant Education Committee for giving me this opportunity to present again at Transplant Rounds, albeit in this particular format. Today, we wanted to focus on one of our staples, our annual staples, which is the healthcare competition called the Dragon's Den competition. And we'll be having two teams present their findings and their work that they have been undertaking over the past year or so in the area of healthcare education. Um, Before I actually continue, I want to also make sure that everyone waits to the very end because there will be a chance for you to vote for the best team at the very end of today's presentation. Thank you. All right, I think we can go to the next slide. So for today's seminar objectives, we pretty much will be focusing on our homegrown program, speaking specifically mostly about the, I would say, the adaptation of our program to, I would say, the pandemic crisis and how we were able to undertake ongoing work throughout the year. We would also focus on some of our upcoming plans with regard to how we're planning and are currently doing assessment and evaluations of ongoing educational programs within the Transplant Institute. And lastly, as I said before earlier on, that we would have a chance for our students to showcase some of their work that they've been working on over the past year or so. Next slide. I have nothing at all to declare for today's presentation. Next one. So the pandemic years for the MOTSRTP. If you go to the next slide, we'll start. I will actually want to remind you guys that we're now in our 12th year, or completing our 12th year since we started, because we started in 2009. We involved teams from various transplant groups like the cardiac, liver, kidney, or infectious diseases as well. Our students this year, we had to try to reduce the number of students that we normally would undertake during the academic year. Normally we have about 30 every year, but this year we cut it down to 20, mainly because of some adjustments that we actually had to undertake during the pandemic crisis. And one great thing that happened because of the crisis was because of the fact that we were mainly operating remotely. And this gives us a chance to recruit from other universities beyond the local universities like U of T, Ryerson, and York. During the school year, we had the chance to expand to other schools outside the GTA for a very successful 2020-21 fall-winter session. We try our very best to stick with our model of education with regards to the MOTSRTP, which is that trifocal approach in ensuring that there is a very strong science base. We unfortunately had to suspend clinical observerships during the school year, mainly because of the pandemic. But we also, as part of our program, did undertake a number of research projects and initiatives, and also give us a chance to focus on mainly completing already existing projects that have been lagging over the years to kind of bring them to fruition. So these are the, I would say, 6 or 7 universities that participated in our program this year. As you can see, that they range from U of T to Waterloo to McMaster and the others. One of the setbacks this year is that our high school Aspire program was not able to take off last year and also for this year, mainly because of the COVID crisis. This is mainly because of the fact that most of the work that the Aspire students undertake really requires a one-to-one mentorship, and we decided that it would be difficult to actually undertake that on while they are, off-site. So we felt that it was more of an on-site program that would require one-to-one mentorship, and we decided to postpone this until probably next year when things may have calmed down. Next slide. So some of our achievements this year, as I said before, because we could actually spend the time to focus on completing already existing projects during the school year, we actually had a record of about 12 publications in a single year of various students' work during the pandemic year. And for about, I would say almost half of them, the students were first authors on many of those papers. So that's a great achievement. We also submitted abstracts to various national and international conferences during this year. And I think one of our students had the privilege of actually having an oral presentation at the Canadian Society for Transplantation, which was a great achievement as well. As much as possible, our PIs got the students to work with many of our databases for as much as could be permitted. We also took non-translation activities like newsletters, and of course the Dragon's Den competition, for which we are here today. And I said before that we did focus a lot on trying to complete ongoing projects. One of the things that we actually undertook this year was to spend some time to evaluate some of our educational programs that currently exist within the Transplant Institute, such as the HSOI program, the High School Outreach Program. One of our students, Cynthia, was the first author of that particular paper. She was supervised by Vicky Ng from Sick Kids, and it was published in the Pediatric Transplantation. And also we did publish the known SPICE and B program in a journal that showed the evaluation of the program after the first 5 years. And that came out in October of last year. So I'd like to thank you all for your continued support of our program over the past year. And we hope that we will be able to offer the high quality service for our students in the upcoming months and years to come. So without further ado, I would like to introduce Zain and Christie, and they will be presenting the first part of Dragon's Den for 2021. And I'll ask them to take it away, please. Thank you.
Thanks, Shaken. I'm just going to share my slides. Hopefully everyone's able to see them. Just a second. Right. Let me know if you guys can see my slides. Yep.
Yes, we can.
All right, I'll take it away then. Hello, everyone. I'm Zain, and today my colleague Christie and I will be speaking on behalf of the Cardiac Transplant Research Team, led by Dr. Carolina Alba. Our project is centered on improving the transplant-related clinical outcomes for adolescent and young adults, also known as AYA patients aged 18 to 30. This project has been ongoing since 2019, and we're really excited to show you our progress this year. Today, we're going to discuss the program, the problem, a recap of our work since 2019, our 2021 project proposal, and then impact and future directions. So the project started because of the growing number of adolescent and young adult heart transplant recipients at the Toronto General Hospital. From 2000 to 2018, 690 AYA heart transplants took place. Despite this, care is still tailored for the adult population, and there is an absence of AYA care guidelines, as well as a lack of educational tools to assist healthcare practitioners in providing optimal care for AYA transplant recipients. When looking further into the differences between AYA patients and adult patients at our center, our team last year found that there was an increased risk of rejection for AYA patients aged 18 to 30 in the first year post-transplant, when compared to adults over the age of 30, shown here by the competing risk regression with a significant difference found between the two groups. This was a great concern and thus warranted further investigation. To learn more, 3 knowledge syntheses were completed: a literature search, patient and healthcare practitioner surveys, and interviews. The literature search was conducted to determine current practices and approaches to AY transplant care and factors associated with poor outcomes within the population. This was conducted in Medline and had 32 full-text articles for review. The 3 main findings were that there are prevalent psychosocial issues in this population, there's a communication gap between patients and healthcare practitioners, and there's a demonstrated need for patient-focused educational interventions. Next, in 2019, the previous cardiac team distributed surveys to 30 AYA patients and 63 healthcare practitioners within the MOT program. They wanted to know what works, what doesn't, and what avenues are there for improvement. A major finding is that 50% of patients had issues understanding medication side effects, 47% had issues understanding what their medications are for, 37% did not understand their treatment plan, and 40% did not understand their medical condition. This is a major concern, highlighting a gap in the knowledge. The surveys also showed that when patients were asked if they had trouble taking their medications on time, only 27% agreed that this was a concern. However, 83% of healthcare practitioners agreed that this was an issue, further highlighting the poor communication between patients and healthcare practitioners on their needs. Lastly, internal and external semi-structured interviews were performed with multi-organ transplant staff and heart transplant staff at UHN, as well as with an AY-specific program at the Princess Margaret Hospital, to learn what major problems are seen in the population and what resources are offered. Not surprisingly, the same emerging themes were found: a lack of care guidelines and tools for practitioners, and a lack of knowledge and communication between patients and practitioners. Overall, the main problems found were that with the growing number of AYA patients at our center, there are alarming differences in rejection rates, and last year's team was interested in exploring whether these rates could be explained as a result of a lack of understanding or low knowledge of transplant care, since the lack of understanding could lead to non-adherence, which has been identified as a potential contributor to rejection. Moving forward, the team planned to target 2 main findings. For the communication gap between healthcare practitioners and patients, as well as psychosocial concerns, they introduced a new assessment tool to be implemented within the clinic. To deal with low knowledge of transplant care, they aim to update and improve educational resources. So targeting the communication gap, back in 2019, the original plan was to alter the current in-person heart transplant clinic. When patients first present at the post-transplant visit, they'll be given a psychosocial assessment tool before seeing the nurse specialist. During the visit, patients will fill out the assessment tool, and based on the results, as well as from discussions with the nurse coordinator, support would be given to the patient based on where they fall in one of the 3 categories. So if mild, they would be provided with newly updated resources. If moderate, they would be referred to community support programs. And if severe, they would be referred to allied health specialists. The form itself was developed based on the existing AYA tool at the Princess Margaret Hospital, but tailored to the AYA heart transplant population. Questions include concerns understanding medical condition, difficulty understanding medication use and side effects, and difficulty taking medications regularly or on time. Unfortunately, due to COVID-19, this project was put on pause. So our current team this year decided to focus our efforts instead on addressing the patient knowledge gap by updating and improving educational resources. So our new plan involves the following.
Okay, so I will take everyone through our 2020 to 2021 project progress, starting first with our resource updates. So our first step was to take a look at the manual, which was specifically designed to support patients by providing them with information on the entire heart transplant process from admission to discharge. The current manual seen on the left was last updated in the year 2000 and does not include information on AYA care, whereas the new updated manual shown on the right was improved by members of the heart transplant staff to incorporate new information and tailor content to the AYA population. So quotes from patients and caregivers were included to ensure that patients feel more represented and more supported. For example, one of our quotes that we included is seen at the bottom. For the first few months, I was back and forth to and from the hospital 2 to 3 times a week sometimes. It seems overwhelming, but it's all part of the healing process, and the transplant team was with me every step of the way. Adapted from the new manual, we created 3 short 1 to 2 minute educational videos to capture the key messages regarding important topics on post-transplant care for the AYA population specifically. These were created on a video editing software called Vyond, and were done to capture the attention of the AYA population in a fun and creative way. So some examples we included on topics are immunosuppressive medications, medication side effects, and the last video we created was on the use of birth control after heart transplant, which we will play a short example. Zain, is audio playing for you?
Yeah, can everyone hear the audio? Okay, let me.
You need to
click
select
Bronte.
the check mark when you shared your slides, if there was audio in the slide.
Oh, okay. Yeah, so is there any way I can do that right now?
Yep, if you stop sharing,
All right.
and then when you share your screen, there's usually an option that says use the audio.
Oh, share sound. Yep, I'm just gonna do that right now. Let me know if it works now. Oh, so it's making me restart my application to do so. So in the interest of time, I guess we'll just move on as opposed to doing it. So.
Yep. All right, so using these updated resources, the manual and the new video modules, we wanted to know, 1, how can these resources be implemented to improve the knowledge of our transplant patients? And 2, how can we ensure that these resources will actually work? So the next step we decided to implement was a quality improvement project, which offers a proven methodology to improve care for patients. So the specific model we will use is the model for improvement method, which is widely used and is applicable to patient care without rigorous training to implement. And it involves 3 steps, the first of which is to set aims for improvement, then choosing a balanced set of measures to determine if this improvement occurs, and then testing these new ideas to change the current process. So these new ideas are then evaluated in a Pdsa cycle shown at the bottom, but I'll walk you through the specific steps of the Pdsa cycle now. So the first step is to plan the test or the study. Then we would try to do the test on a small scale, which would be our pilot project. After testing it out, we want to analyze the data and study these results. And then based on what we learn, we can then act to refine our video modules and then change them to meet patient needs. So what exactly are we trying to accomplish? The aim for this project is to improve AYA patient knowledge on transplant care to 80% within 3 months. And as evidenced by our surveys in 2019, our sample knowledge for some topics was as low as 50%. So we aim to improve that to 80% in the hopes of ultimately increasing adherence to transplant care and improving clinical outcomes for future heart transplant patients. In terms of how we will know a change is an improvement, we are interested in 3 measures to quantify the success. The first is outcome measures. These evaluate the effect of the system on patients themselves. And the outcome measure that we are interested in is patient education assessed through knowledge quizzes to test if these updated resources will improve knowledge. The second measure is process measures, and these evaluate system performance and potential changes. So this will be assessed via patient satisfaction surveys about video quality and content. For example, one process measure that could potentially impact educational outcomes is technology accessibility, such as working internet or subtitle usage. And lastly, balancing measures are monitored to study unintended consequences of changes to a system. And to assess this, one-on-one interviews will be conducted so we can learn more about patient experience. For example, we may find that patients with a stronger knowledge may be more engaged with their transplant care, and this can prolong appointment times or increase the number of calls that our nurse practitioners receive. So now we will walk you through our Pdsa proposal. So this is an example of one cycle that we are planning to achieve. So we will be conducting a 12-week study with the aim of recruiting 10 patients in total. And starting with our first 3 patients, they will be randomized into either Group A or Group B and receive either the manual first, which is the standard of care, or the new educational videos first. So randomizing the order that patients receive these educational materials will help our team understand if the new video modules that are created can improve knowledge better than the standard of care. And after receiving the educational content, patients will then complete a quiz. So those in the video group will also receive a survey and the one-on-one interview once the quiz is completed. So after 2 weeks, the groups will receive the other modality and the steps are then repeated. So using the Pdsa cycle, we will use the results from the survey and the interviews to update the video content and repeat the process again for the next set of patients until all 10 have gone through this process. Okay, so walking through the quiz now. The quiz seeks to assess the patient's knowledge and understanding of transplant care-related concepts upon either reading the manual or watching the videos on a specific topic. So the quiz will contain 15 questions in total. There's 5 questions per topic covered, and the quiz will be administered over Google Forms. So a sample question that was included in our birth control video quiz is, why is it important to use birth control after transplant? And based on how well the patients do on this quiz percentage-wise, that will be our determining factor on the confidence and understanding of the concepts provided by the educational modules they received. For example, if patients received 12 out of 15 on this quiz, they would have an 80% understanding of the educational resources that were provided to them, and that would be the minimum target score for our project. So all data will then be collected via Google Form and then exported to Microsoft Excel for analysis. So patients who receive the video modules will then partake in a survey online to gauge feedback with regards to the videos and subsequently use them to refine them. The survey contains questions assessed using Likert scales on accessibility of the educational modality, ease of use, confidence in the skills gained, and also questions on personal preference. So here's an example of a survey for our video modules. And all of this data will then be exported for analysis into Excel. And lastly, 15-minute semi-structured interviews will be done with patients after they use the video modules and complete the quiz and survey. Interviews will be conducted using phone and online conferencing technologies, and open-ended questions on patient experience will be asked. So some sample questions include what was effective, what was not effective, and further questions to elicit feedback on what could be potentially changed. In terms of actionable items in our due stage, the first step would be to complete patient recruitment. So we would like to reach out to our current patients and have them provide their name, their phone number, and their email address, and also sign a consent form. The second step after this is completed would be randomization of our participants using a randomized via online generator. And then once this step is completed, we will be able to send out an email with the video and manual content 24 hours after the consent form is filled. So patients will receive approximately 1 week to complete the quiz and accompanying survey, and a reminder email will be sent to them on day 4 if this process has not been completed. Lastly, one-on-one interviews will be completed in week 4 of the study using online technology or via phone calls. So the evaluation plan in our study stage is as follows. Data will be exported to Microsoft Excel for analysis. And analysis for the quizzes will include summary statistics and paired sample t-tests for each individual scores from the 2 modalities. Survey data, including Likert scales, will be summarized using descriptive statistics, and interviews will be summarized and analyzed using qualitative thematic analysis. Based on our findings, we will reevaluate our measures to see where changes can be implemented. So our first consideration would be our outcome measures to decide if changes need to be made to the video content or development. So some ideas that we have already had are adding subtitles or bigger fonts, or adding a frequently asked questions section onto the heart transplant website. We will also be evaluating process measures for patient feedback and see if videos are a reasonable intervention for this population. And an idea that we have is creating an online resource hub shown here, partnering with UHN Digital if videos are shown to be more effective. We will also be using balance measures to see if any unintended outcomes arose, whether positive or negative, and if further additions or changes should be made to updating of educational content. So again, the study and asked portion of our first Pdsa cycle will be completed after the first 3 to 4 patients. The Pdsa cycle for the next 3 to 4 patients will continue until we reach our target recruitment. And we aim to complete about 3 Pdsa cycles to reach our goal, which is having AYA patient knowledge on transplant care to 80%, which we approximate will take 3 months to complete.
Looking to the project's impact, we anticipate that at the patient level, we will increase patient accessibility to support and resources, we'll promote and increase post-transplant care knowledge, and we will ultimately improve patient care adherence. At the staff level, we'll reduce unnecessary burdens due to lack of communication, improve conversations with patients on care concerns, and ultimately increase healthcare practitioner satisfaction. And at the system level, we'll improve adherence to medication and clinic visits, increase continuity of care, and lead to an overall more efficient and cost-effective healthcare system. With regard to our progress, over the past year, we have submitted our quality improvement project form to UHN for approval. We heard back from them with feedback regarding the preamble for our questions and have now sent it back to them for final approval. All quizzes and surveys have been developed on Google Forms, and all consent forms, patient information forms, etc., have been developed. Some aspects to consider include the cost of creating video modules. So the basic Vion plan is around $40 US a month. Ensuring that video content is up to date and continues to be useful to patients will require further communication with the transplant care team while balancing these costs in mind. We hope to address this through identification of grants or allocations of funding. Furthermore, we anticipate that some patients may not have regular access to a computer or phone and will thus be unable to watch the videos. If technological resources cannot be provided, we will ensure that patients are given the basic standard of care through the manuals to ensure their education on transplant care is not compromised. Additionally, we will ensure that our video modules are compatible with a wide range of browsers and devices. It's essential that throughout this process, we continue to promote interest and support amongst our healthcare staff by knowledge dissemination through presentations in transplant rounds such as this and across UHN. This is a timeline of our future plans. From April to May, we are planning to start recruitment. From May to August, we plan to complete our QI project, which will involve the administration of baseline and intervention content quizzes and patient questionnaires. In September, we will then review and analyze the results to determine whether to proceed with the development of additional video modules. And finally, in the fall of 2021, if the videos are found to be an effective tool, video module development will commence and we'll begin collaborating with UHN Digital. Speaking to the applicability of our project, currently there are no transplant centers in Canada that have an established educational system to address the needs of AYA patients. Our pilot program will be the first of its kind to address this gap in knowledge and help improve AYA-specific clinical outcomes by hopefully reducing future patient rejection rates and non-adherence by increasing education. Future applicability will be internally at UHN to kidney, liver, and lung, as well as chronic disease programs, as well as externally to other transplant centers across Canada. That brings us to an end of our presentation. We would just like to thank Dr. Alba, Stella Kozushko, Serena Peck, and Shagan for all of his support. Thank you.
Thank you very much, Zain and Christie, for a great presentation. I would probably permit about 2 questions or so from the audience, 2 to 3 questions before we move on to the next presenter.
Sorry, I don't know how to raise my hand.
Okay.
Can I ask a question?
That's okay. We can hear you.
Okay. Hi, I'm Cynthia Tsan. I'm with the liver transplant team. That was a great presentation, and I'm really impressed with the amount of work that you guys did. Just a quick question, was there, and I may have missed this, was there any thought about engaging a patient sort of along the way, like throughout the entire process. So not necessarily just at the end getting feedback, but potentially, you know, from the very beginning to kind of decide like what was important, you know, like what educational modules should be focused on. Like, is there any thought of doing that if you haven't already done that?
Thank you for the great question. We do have a patient who's helping actually develop the manual itself. And so thus the information in it is targeted to specifically what they'd want to see in that. And then that coupled with the feedback that we get from the videos would help us really make sure that it's a patient-informed process.
Great, thank you.
If I can ask one question. So
Yes.
since Shagan has said that I can ask only, he is going to allow only 2 questions. So
Oh,
I'm
3.
going to mingle it. 3. Okay. So don't you think the crossover design that you're using in your trial is going to contaminate the results? And what are the plans for long-term retention of your education? You understand what I'm saying? So you are assessing the knowledge at 4 weeks, 6 weeks, or when you're doing the interview, right? But this is a lifelong disease that they're going to have. So is there any plan for a reinforcement or checking the long-term retention? Because, you know, we all forget over time. And the crossover design that you have looked at, what is the risk of cross-contamination in people who are in group A, then go to group B, and then see the same intervention?
Yeah, so with regards to the crossover, if I understood the question correctly, group A or group B, they're both going to be looking at the manual, which is the standard of care already, and then the videos. And so the manual of care, the manual is something that they're already going to be seeing and they have, whereas we just are doing this to see whether the videos are effective at increasing their education in addition to the manual to begin with. And then speaking to the longevity of this, the Pdsa cycle so far is short term in that we're just going to reassess, reevaluate, and see whether the videos are feasible. But then we will continue to update them throughout the process as we learn more about concepts that they want to see and stuff like that. Hopefully that answered the question.
Yes, for long term for sure, but
Okay, thank you, Dr. Hussain. Any other questions? Okay, in the absence of no questions, we'd like Bronte and Emily to present their own work for the kidney team over the past 1 year.
I'll be sharing my screen. All right. Thanks, Emily. Shagan, is it all right if we begin?
Yes, you can.
Perfect. Good morning, everyone. My name is Bronte, and alongside Emily, I'm delighted to be seeking your support for our project, the Kidney Transplant Learning Project, herein referred to as the KTLP. So we all know that across various stages of the kidney transplant and living donation processes, patients are confronted with an immense amount of information to learn and digest. This information comes from a variety of sources and in a diversity of formats as well. As you can imagine, it's extremely challenging for patients to both locate and navigate all of this information, not to mention it probably isn't fun either. One of our teammates brought up the point that if most of us can't even be bothered to read the terms and agreements before updating our phone software, it's hard to expect anyone to be thrilled about the prospect of gathering, reading, and trying to understand dozens of pages of information about the pre-kidney transplant process. So can something be done? We think that the answer is a resounding yes. So today we are pleased to present a solution. Our aim is to creatively centralize educational material in transplant in order to uphold and reflect our status as innovators in transplant education. And accordingly, our objectives are to firstly standardize and synthesize existing information from all of these different sources. Secondly, to increase accessibility and navigation of transplant education for patients. And finally, to improve workflow for healthcare practitioners. So you may be wondering if this is easier said than done, and our goal today is to convince you otherwise. We'll discuss our project's evolution and structure, we'll showcase a prototype, debunk some limitations, and finally explain where we're headed. So to get us started, I will pass things back to Emily.
Thank you so much, Bronte. So I'll be going over our project evolution, so how it started and how we adapted after the onset of the pandemic. Upon our discovery of the non-centralized and hard to navigate patient educational resources, we proceeded with a three-pronged investigation consisting of an environmental scan, a knowledge synthesis, and stakeholder interviews. We identified several barriers to patient education, including patient confusion and inability to retain information, difficulty in locating the resources, and a general lack of awareness on the part of many healthcare providers of the resources offered by our institution. In addition, we also evaluated the kidney transplant manual, which is the primary resource provided to transplant patients before and after their transplant. We found that the manual was extremely long. It's 155 pages. It also had spelling and grammar errors. It had outdated information, and it also did not cover some of the difficult topics that would concern patients. For example, how a recipient should ask family members and friends to be a potential living donor. So to address these barriers, we proposed a transplant health information kiosk as a solution to centralize educational resources in a user-friendly and accessible hub that would be placed in both outpatient and inpatient transplant clinics. However, amidst the pandemic, this solution was not feasible and we had to adapt our project. There were several changes brought about by the pandemic, particularly the transplant health information kiosk idea was not feasible because there was no access to the kiosk from home. There was also sanitary concerns regarding the touchscreen design, and there were also no trainees on site to manage the kiosks during the launch. Additionally, UHN converted from in-person to virtual educational consults, which were occurring through phone or a video conferencing platform. And this format was difficult for some patients to navigate. It was more time consuming for nurse coordinators, and it also made it more difficult to assess patient understanding due to a lack of nonverbal cues. So the need for more accessible and centralized resources became even more pertinent during this time. And as a result, we proposed a new solution, the Kidney Transplant Learning Project, or KTLP for short. And it is a compilation of animated videos and quizzes on transplant-related topics covered in the transplant manual, as well as other sources like educational teaching slides from nurse coordinators and social workers. The KTLP has many benefits. For example, it's very conducive to both visual and auditory learning styles. It also emphasizes active learning through the end of video quizzes. It also optimizes the nurse coordinator's time by explaining difficult concepts in advance of teaching sessions. It's also very easy to refer patients to this accessible resource, which can be placed online. And it's also a very feasible project overall because it doesn't require many resources, as we'll be showing later on in our presentation. So our overall long-term outcome goal is to improve patient education resources and access to healthcare information. So now I'll be discussing our project structure and workflow. So this graphic demonstrates the overall process required to make a completed educational module, going from curriculum development to script writing, to quiz creation, to storyboards, to animations and voiceovers, and finally prototyping and feedback. And I'll be going over the details of each step in the upcoming slides. So first, I'll speak about the curriculum development. So the recipient team started content development last summer through consultations with nurse coordinators and Dr. Kim. Together, we designed a curriculum that is broken down into 10 modules with over 30 videos in total. And the information was drawn from the kidney transplant manual as well as the teaching slides. And as you can see, there are many topics ranging from introductory, what is the kidney transplant program at UHN about, all the way down to the transplant assessment process and life after transplant as well. And we also decided to create the prototype for the deceased donor kidney module first, because after consulting with nurse coordinators, they identified it as one of the most challenging topics for patients to grasp. In terms of the donor curriculum, the student team consulted with Dr. Singh and nurse coordinators as well. And the content draws from the existing Living Kidney Donation Manual and teaching slides. And it consists of 6 modules: the Living Kidney Donation Program, Donor Evaluation Process, Kidney Pair Donation Program, Donor Surgery and Follow-up, as well as non-directed anonymous donation. And a very key difference between the recipient and donor content is that each donor module will be one video rather than a series of videos. And this is largely due to the fact that there is less donor-related information. So the next step of our workflow is to write and edit our video scripts. So the first part we start off with is development, and we gather content and synthesize it from the existing educational resources. The students in our team write it and we edit internally amongst ourselves. After, we send it to the nurse coordinators for review and we incorporate their feedback. The next step is we send it to a nephrologist, either Dr. Kim or Dr. Singh, and incorporate their feedback. And then the last step is to have all of the scripts edited by more transplant physicians. And throughout this whole process, we also consulted with specialists from social work, the Trillium Gift of Life Network, and the multi-organ transplant coordinators for information that was either missing or wasn't clear in the manual. So the third step of our project is the quiz creation. And there is one optional quiz per module for patients to assess their learning. And the quiz content is based on topics that were covered in the video and ranges from 3 to 5 questions. Explanations are provided for both correct and incorrect answers, and patients have unlimited attempts to do the quiz throughout their transplant education journey. And some points that we really want to emphasize to patients is that it isn't graded and their performance doesn't affect their listing, and it can also be anonymous if they would like. So after completing the scripts and quizzes, we started creating storyboards in September 2020. We used Google Slides for this process so that the storyboards could be shared and reviewed by other members of our team. And we finished creating over 30 storyboards in December 2020. As you can see in this slide, on the top, we have the recipient content, and on the bottom, we have the donor content. And you can clearly see that there is a consistency between all the graphics, fonts, and colors that we used between our two teams. The storyboards are then brought to life using Microsoft PowerPoint. Initially, our team experimented with an Adobe software. However, we found that this prevented several students from working on the storyboards at once. And over time, the storyboards and software would incur a significant cost because the software requires a monthly subscription. We also found that Microsoft PowerPoint is more user-friendly and can allow changes to be made with more ease if required in the future. So next, the screen-recorded PowerPoint presentation is imported into iMovie, along with a voiceover clip that reads out our script. And the program allows us to sync both the audio and visual components to form the fully fledged video. In February, the recipient team completed this whole process for Module 5 on the topic of deceased donor kidneys, which of 4 videos. On standard criteria kidneys, the second is on extended criteria kidneys, the third and fourth are about exceptional distribution kidneys, focusing on increased risk kidneys and hepatitis C positive kidneys. So we will now show a portion of one of the prototype videos for Module 5. It's going to be the final video in the series, so the hepatitis C positive kidneys, and it will also provide a summary of the entire module. And the full video is around 6 minutes, but we will only be showing 2 minutes for the purpose of today's presentation.
In our last video, we discussed how increased risk donor kidneys are considered exceptional distribution. Hepatitis C virus, HCV, positive kidneys are also a type of exceptional distribution kidney. In this video, we will be discussing what hepatitis C virus positive kidneys are, and this will conclude the module on deceased donor kidneys. A hepatitis C virus positive kidney is from a deceased donor who has tested positive for the hepatitis C virus in the blood. This type of transplant will have almost a 100% chance of transmitting hepatitis C virus to the transplant recipient. The virus will enter through the bloodstream and may cause liver damage or even liver failure if untreated. We have finished our discussion on hepatitis C virus positive kidneys. You can find more information at the link at the end of this video. Let us summarize this module. In this module, we learned about the two types of deceased donor kidneys, the standard criteria and the extended criteria. We will support the decision you make, and it will not affect the quality of care we provide. There is a short quiz that can help you assess what you learned in this module. Thank you for your attention, and see you in the next module.
All right, so with Dr. Kim's help, we disseminated these videos to transplant physicians, fellows, and the biomedical communication team for their feedback. And we asked for feedback on both the video script, so the voiceover, as well as the quality of the video. And we had several feedback domains that we asked for feedback on, including content accuracy, whether or not it was easy to understand, the voiceover quality, the graphics, speed, and overall visual aesthetic. And as you can see, this is just some of the examples of the feedback we received on our video, in addition to extensive edits on our script. So there was some that said that we might need to change our wording for health literacy criteria, comments about the speed. There was also some comments about the graphics and logo. And there was also support for voicing over the videos in other languages. And this whole process has been very helpful in shaping our final deliverable through getting all of this very valuable feedback. So now I'll be talking about initiatives that we've taken to help us carry out our process. The success of the KTLP is largely based on the easy maintenance of the modules. And to make this happen, we are currently drafting a manual to inform future development and current development procedures. And this will be formatted very similarly to other MOTSRTP student training resources for patient data collection, for instance. And it'll outline details such as information sources that we've used, for example, the manual and teaching slides. Will also contain software instructions for PowerPoint and iMovie. And we'll also include information about image licensing for graphics and then formatting in terms of text, font type and size, as well as the overall aesthetic. And this manual will be made accessible for future students and staff involved in updating the existing modules or through creating new ones. And throughout this whole process, we've also been able to secure funding to support our project. In September, our team participated in the Center for Living Donation pitch competition and placed second, receiving a $3,750 award for our project, which we've used towards software and hardware, such as purchasing a microphone for voiceovers, as well as gift cards that we hope to give out to the patient focus groups. And in January, we also applied for the Chinese Community Development Fund. We requested $1,100 in support to translate our prototype module, which I just showed. The script we wanted to translate into simplified Chinese so that we can offer subtitles in the language and make them accessible to a wider audience. And finally, just to stay on track, our team has been recording our progress in script writing, animating, voiceovers, and feedback collection in a spreadsheet on Excel. And as you can see, there's a lot of green as we have done a significant amount of work since the start of our project. So I'll now pass it over to Bronte, who will wrap up our presentation by speaking about the evaluation and future directions.
Thanks, Emily. So how will we assess our project? In the short term, we will evaluate our prototype by eliciting feedback through focus groups and surveys. Results will inform additional revisions to our work. Focus groups will be held with patients from the African, Caribbean, and Black Kidney Health YouTube channel advisory team, as well as our local patient advisory council. And then in terms of the survey, some of the domains we'll elicit feedback on will include things like speed, sound quality, length, graphics, similar to what Emily mentioned earlier. In the long term, we will elicit feedback from patients and providers regarding domains such as usefulness, accessibility, and support for continuation for the KTLP. And questions for patients, as shown on the screen, will range from things like, is the module content relevant and comprehensive, to what features of the KTLP could be added or improved. Similarly, questions for providers will range from, do nurse coordinators have more time during visits to address other aspects of patient care, to does the KTLP improve or diminish overall work satisfaction? As with any project, we are not immune to limitations. Firstly, access to the KTLP does require patients to have access to the internet and a viewing device. However, face-to-face or over the phone teaching will of course still be available to patients in need. Secondly, maintenance will be required to accommodate time-sensitive information. However, as Emily mentioned, we do have that manual in development, which will really ease future handover and make it extremely easy for anyone to take part in this project. And then lastly, right now our modules are currently available in English only. However, translation services and the requisite funding are in the process of being sought. Now, on the next slide, we'll just show you what we hope to have in the end in terms of subtitles in different languages to improve the overall acceptability of our work. So where have we been and now where are we headed? So between last fall and this month, we completed the knowledge synthesis portion of our project, storyboard development, as well as some preliminary fund sourcing. And from now through the end of this summer, we anticipate to complete the digitization of all of the English modules, as well as hopefully some preliminary language translation as well. We'll also continue developing our manual, we'll review our prototype, and conduct further evaluation planning. By next fall, we hope to be ready to conduct a focus group, make some final revisions, and prepare for a soft launch. And by winter of next year, we hope to be ready to participate in some knowledge dissemination and exchange, as well as begin evaluating provider experiences. So now that we've explained our project's evolution, goals, structure, and future directions, please allow me to summarize just what we have to offer and really why should you support the KTLP. So here are our selling points in a nutshell. So firstly, we intend to yield benefits for patients. To improve the patient experience, we will streamline access to educational materials by offering videos in different languages that are particularly helpful for auditory and visual learners as well. We also expect to improve provider satisfaction by minimizing the need for face-to-face teaching and hopefully reducing the need to address repetitive queries. So now patients will have the convenience of pausing, rewinding, or rewatching any of the KTLP content for clarification instead of having to inquire about a concept mentioned momentarily during the start of an in-person teaching session. And then finally, we also plan on ameliorating system efficiency by reorganizing staff and patient interactions, as well as increasing patient responsiveness and self-efficacy, thanks to overall improved understanding of their care. Overall, we believe that the KTLP is extremely applicable. Our project will remain relevant well beyond the COVID pandemic and is easily adaptable for other organ groups. We've developed a user-friendly method that can be employed across many fields and one that really prioritizes consistency and quality. KTLP is also highly accessible. Patients require very, very few resources to access our videos, and our educational resource should actually save them time and energy overall. And finally, but not least, the KTLP is incredibly feasible. In fact, we can't stress this enough. In a few short months, we have refined an approach to module development and production that requires minimal training, as well as takes advantage of cost-free resources. Apart from translation services, our project can be completed and maintained without the use of any paid software subscriptions and without the need to outsource or contract external parties. So really, it might sound trite, but anyone can make the KTLP a reality. Finally, these are the many people we'd like to thank for their assistance and encouragement. And on behalf of our teammates, we thank you in advance for your support and would be happy to answer any questions. After this question period, we'll invite you to vote for a Dragon's Den winner by completing the form on the screen, and I'll also put the link in the chat. Thank you.
Thank you very much, Bronte and Emily, for that very great presentation. And as we said, we actually have the link that's been displayed for you. It's also in the chat. Please click on that to please place your votes as to who would be the winner at the end of today's presentation. So we have time for 2 questions. Cynthia?
Thanks so much. Again, a really impressive presentation. Great job, guys. You discussed in your limitations that some patients might not have access to internet connections and computers. Did you do any sort of preliminary survey to kind of get a sense of what that proportion of patients might be? Like, given that your population is probably a bit older and less tech savvy than, say, like the other population that was discussed earlier?
Yeah, thank you so much for that comment, Cynthia, and question. So we haven't conducted a survey yet to ask that, but we're currently working with the patient advisory groups like Bronte mentioned, and that's definitely something that we hope to include in our survey just to gauge the population in terms of their needs, and we'll definitely be asking them if they have access to technology when we run the prototype by them.
May I ask one question?
Sure.
So very nice presentation, both of the groups. So it's very nice, it's very fancy, it's hip, it's videos and all this stuff. How are you going to judge the knowledge retainment or improvement in the knowledge or understanding of the topic? By just those questions, those are at the end of the module? Or is there any other way you're going to develop people who have used this? You're going to send them some surveys later to see what they have liked or retained.
Sorry, that's a great question. Thank you so much. I think this will really rely on almost some triangulation. So in addition to having the surveys immediately after the modules, we'll be able to provide feedback, or sorry, elicit feedback later on in the process. And furthermore, we'll also have a chance to sit down with patients and gauge their perspectives on whether they feel like they've understood the concepts, which I realize might be problematic if they have, recall issues that they might not actually be aware of. But I think we'll be able to judge a general sense of whether they find things easy to understand and feel more confident about understanding their care. And furthermore, we also hope to chat with providers, particularly nurse coordinators, who usually are their first point of contact for clarifying confusions that patients may have. So I think we'll have to come at it from a variety of angles, but that's a great question and something we need to think about further in terms of evaluation.
Yeah, and it's all well and good. It means I think you've thought of it, but just make it a standardized process, right? So these are the things that you're going to check with coordinators. These are the things that you're going to check with patients. So make it a standardized process and standardized questions for retainment. Because we all is going to benefit from this, right? And some of the contents will be non-center specific, right? That can be disseminated to other centers also, who don't have this ability to develop these learning modules.
Thank you very much, Dr. Hussein. I think that we've come to the end of today's presentation. It's almost already 9 o'clock. I would like to ask Emily to project the winner graph of who actually did, I would say, become or was crowned the winner of this year's Dragon's Den competition. Emily, did we actually have that graph?
Yes, I'm just taking a screenshot of it right now. Just give me one second.
Give us 1 second to display. Drum roll, everyone.
While we are waiting, I want to congratulate both of the teams for the excellent work. You have to decide a winner in everything does not necessarily mean that you undermine the efforts of the other team. Both of these are excellent projects, and I see they do have impact in terms of patient care. So congratulations to both of you. I don't know who the winner is. For both winners and the group who didn't succeed this time.
To me, I feel that they're both winners anyway. So
yeah.
Well done, team. Well done.
So the winner of the Dragon's Den 2021 Healthcare Innovation Competition is the Kidney Transplant Learning Project.
Okay, well done. So, I mean, again, thank you very much for all the hard work that you both put in over the past year, especially in this pandemic year. It's been very challenging, and that you're actually kept focused on your ongoing work. We both want to see both of these projects come to fruition, so we will be keeping tabs on that over the next year or so. Well done, Zain and Christie, for your hard work, and Bronte and Emily as well. And thank you, the audience, for coming to listen to our annual presentation, and we hope that next year we'll also have something similar to showcase for you guys. So thank you.
Thank you.